All right, thank you. So I might not even take the 30 minutes. I know that usually when you present to physicians, you're supposed to have 50 slides for 5 minutes, but I've tried to keep it to 10 for 30, so hopefully we can have a substantive discussion on some of these megatrends. For those of you who don't know, the Healthcare Incentives Improvement Institute, or HCI3 for short, designs and implements payment programs and other incentive-based programs to improve quality and affordability of healthcare. So we don't just, as I often tell people, we're not really a think tank. We're more of a do tank. We go out there, we work with employers, with payers, state and commercial, as well as providers in a collaborative way to try to figure out what's going to work, what's going to help, what's going to move the dials in a meaningful way. And as introductory comments to really the discussion with your colleagues on this upcoming panel, I wanted to touch on just the importance of really understanding the effect of these two, what I call mega trends, in reshaping the delivery system over the next decade or possibly 2 decades and really forever. And certainly we've talked this morning about the move to alternative payment models. I think what's important to understand and can't be underscored enough is that this is a bipartisan agreed-to move. Right, so it's not as if you have one administration thinking that movement to value-based payment models, alternative payment models, is important and the other one does not. There is very broad bipartisan agreement, and not just in Washington, which, as we all know, is a rarity, but also pretty much everywhere in the country. So if you look at what's going on at the state level with Medicaid reform, you've got blue states like New York, red states like Arkansas, and purple states like Ohio very actively involved in statewide wholesale alternative payment model deployments through the combination of their Medicaid programs, as well as in many instances the state employee program, and engaging the private sector payers to double down and work collaboratively with the state on implementing these new payment models. So as a result of which, this movement is not going to go back in any measurable way, but I do think that it's going to continue to accelerate as the lessons are learned from more and more of these state implementations, as the lessons are learned from the private sector, and even as lessons are learned from the federal programs. Some of this, and again, this is important to understand, is that some of this is also stimulated not necessarily at the federal level, but certainly at the state level and the commercial level, both plans and employers, because of the middle class squeeze. And I know, especially in this election year, we hear a lot of rhetoric about the dwindling incomes or the stagnating incomes of the middle class. But when you start putting it into real dollar terms of what it means for a family that is insured with a silver plan in any one of the exchanges. And I use that as an example because that type of benefit design is now ubiquitous, not just on exchanges, but really offered by many employers and health plans throughout the country. So when you look at what kind of coverage they have, the amount of deductible that they have to meet every year before the third-party insurance kicks in, and then the continued cost sharing that they have to support all along the way through their out-of-pocket expenses, it can consume easily 20% of a family's income. That's a substantial amount. When most of us are roughly of the same generation in this room, well, when I was growing up, the rule of thumb was with your revenue, your take-home pay, the rule of thumb was about 30% for home and home-based expenses, food, utilities, mortgage, or at least mortgage and utilities. Then you had a third for savings and retirement, and another third for discretionary spending. Well, if you have 20% now that's consumed by healthcare expenses, it crowds out basically everything else. And that's a real problem. It's not a hypothetical problem. It's not just quoting averages. It is a real problem. And when you look at the effect of that problem on, for example, the rise in accounts receivables by most hospitals, it's having a direct financial impact on many hospitals across the country who are seeing the increase in their accounts receivables because of the deductibles. They're not collecting on them. What they're doing is they're turning around and they're factoring them or selling them to third-party debt collection agencies for about 20, 30, 40 cents on the dollar. And those people are ruthless, and they're pushing then these families into bankruptcy. And again, these are not anecdotes. It's now, when you start looking at the number, the continued increase in the number of families who are declaring bankruptcy for healthcare reasons, it's on the rise. The debt ratios are on the rise. So it is having a real impact. When things like that happen in any country, there's a reaction. So that means you start going and having very different discussions with your state and federal legislatures, and that has created, for example, the movement towards transparency. It is not an accident that everyone talks about price transparency and quality transparency. It's not as if most of us in this field haven't been talking about price transparency and quality transparency for now, close to 20 years. But what has happened in the country then in the past 5 years, 2 years, 3 years, one seemingly innocuous article from Time magazine inflames the spirits of a large majority of the U.S. population. It's because of the middle class squeeze. So it can't be underestimated, and the power of that trend can't be underestimated. So the high deductible health plans have had the effect that I think many believed it would, which is it has turned consumers into healthcare consumers. Now, we know that comes with good and bad. The bad is they are foregoing both needed and unneeded services. The bill on that is going to come due at some point. But in the interim, it is causing a lot of shifts in the industry, and that is not going to go anywhere soon. So what are the implications? One, and again, this is very, very clear, when it is the consumer's money, they make very different decisions. And we've known this since the Rand Health experiment of the 1970s and 80s. Again, that showed that when cost sharing increases, individual consumption of healthcare services goes down. So it's your money, you're making different decisions. But it's not just about whether or not I decide to go and get healthcare services. It's also, if it's my money, what am I expecting as part of that service? What am I expecting? So the expectations of what I should be getting from those who care for me are changing. They have changed, and they're going to continue to change. I expect a lot better customer service because it is my money. It's not someone else's money. It is my money. I expect more convenience. I don't expect to be billed for things when they go wrong. I do expect to know upfront how much I'm going to have to spend. I mean, these are normal expectations. And as I tell physicians, think of yourself as a consumer. Don't you want those questions answered also when you buy stuff? Would you accept to go and purchase what you purchase on a day-to-day basis and have no way of knowing upfront what it's going to cost and then just absorb the bill on the back end? No, of course not. Right? So why should we expect consumers who are spending literally thousands of dollars out of their pockets during the course of the year to not expect a lot more when they hit your offices and before even they get to your offices than what has happened in the past? So transparency then becomes an absolute necessity for doing business. You cannot get away anymore with simply saying, gee, I don't know, we'll find out when the test is done. Yeah, you're going to find out when the test is done, but you should be able to give a reasonable estimate of what all this means. Right? What is going to be the price that I, as a consumer, are going to have to pay out of my pocket? And we talk about colonoscopies, and I'm going to show some examples in a second. But as you know, there's only a certain category of colonoscopies that are covered in full under all health plans, and those are the ones that fit tightly within the definition of a preventive colonoscopy. Anything that is diagnostic is not covered under routine preventive care services and is therefore subject to 100% of the deductible to the extent it hasn't been met, and certainly co-insurance. Now, what's the average cost of a diagnostic colonoscopy? If you don't know, transparency as a necessity for doing business.
It's a complicated question. What's colonoscopy? What is in your cost?
Yeah. Okay. So answer the question from the consumer's perspective. Right? You are seeking a GI practice because you've been told that you need to have a diagnostic colonoscopy done. Tell me how much it's going to cost.
Where's it going to be done? Out of anesthesia?
What insurance policy do you have? They dictate what you need to pay. What the contract is. The doctor.
Okay, so I'm covered by Horizon Blue Cross Blue Shield, and I've got a high deductible health plan with a family deductible of $5,000 and a co-insurance of 20% all the way to $10,000.
I guarantee that Horizon Blue Cross Blue Shield is different payment for one facility versus another.
I agree, but I'm
Doctor gets paid no matter what.
I'm asking you.
You can't tell them.
Yes, you can. Right, exactly. And if you actually know how much... No, but it isn't. So in other words, if you know that the facility X is going to charge so much for facility costs, but then you find out.
No, they need to find out.
No, you need to find out.
Insurance industry.
No, you need to find out. Think of it again. It's your money. You're going to make very different decisions. So I'm a consumer.
But see what happens in the hospital. Like my hospital across the street is not going to tell me that they get paid $5,000 for a facility fee. They won't. They won't. So I can't tell the patient that 'cause it's not.
All right. So let's play this out. So I'm a consumer. Yeah.
There was another paper recently, I think it's in the Hamilton Journal, by some of the CalPERS out in California
Yeah.
about screening colonoscopies and the copay, and they found the quality was pretty much the same.
Right.
Because the ambulatory center in the hospital, so all the state employees did it where, it's cheaper.
Exactly.
I've got the slides in my talk, but I can tell you the Consumer Reports and the CalPERS and Safeway, the reference price, $1,200. That's facility fee plus professional fee to the colonoscopy.
Right.
No PAP, no anesthesia, no
Right.
anesthesia, no biopsy. It's just colonoscopy, facility fee
Right.
plus.
It's a lot more expensive if you add those things. My point is, if you call the facility and you say, look, I now need to give this information to my patients, and you have a choice. You either tell me how much it's going to cost them when I send them to the facility, or I'll go to XYZ place because they've told me how much that is. How long do you think it's going to take for that facility to give you the answer? Because if you move that business to another facility, they're going to come begging, to get.
Contracts with Blue Cross Blue Shield, they cannot tell you that because it's not. They don't have the transparency.
All right, Lily, are physicians allowed to disclose facilities allowed to disclose how much they negotiate with you if they want to, or does Horizon Blue Cross and Blue Shield have gag clauses that preclude hospitals from sharing information with their colleagues on how much you're reimbursing them? So you force the facilities not to disclose their fee schedules.
Our fee schedule for our practice, it's on our website. It's been there for 5 years. On our charges. Our charges, you can go by CPT code, you can look the right on our website. Not reimbursed.
Right, yeah.
So that's our name.
We're not in that, but when we provide information to our partners in the episodes, we provide information for every patient who goes for every episode, like a take-home service.
Right.
So you don't have to be
A genius to figure it out. Exactly. So there are ways, the point is, even if that's true, there are actually good ways of figuring out what those differential costs are. Look, this isn't easy, but the point is, if the range is somewhere between $25 and say $6,500, and I have a $5,000 deductible and a 20% coinsurance, that's the difference between my having to write a check for $2,500 versus $5,000 plus? Isn't there an obligation to let me know that ahead of time?
Absolutely.
Won't someone at some point figure out how to tell me this? And won't I, as a consumer, go to those who can answer that question over those that can't? Yes.
You have to call your insurance.
Maybe, but look at we're seeing examples, and a lot of them. We're seeing examples of physicians, GI groups, negotiating those prices up front with payers because they want to be able to answer that question, or at least gaining enough information in their market that they can answer that question, or maybe setting up their own facility so that they can truly answer that question because they know how much they're getting reimbursed. The point is, when it is your money, you do make different decisions, and transparency becomes the condition for doing business, right? It's not an option. And I'm not saying it's going to happen tomorrow, but we are seeing enough signs of enough providers and enough specialties taking a proactive role because the pressure is mounting. Right? This isn't fantasy. It is people's money. It's not the third-party payers' coffers that are being pulled into this. It's an individual family's income, 20% of which is now being used. If you have a couple of chronic conditions, 20% of your income is being used for your healthcare expenses. So there's a different demand, there's a different expectation. And I think that brings to the third point, which is accepting for physicians and providers to accept financial risk for care delivery, including warranty risk. And here the point, I think, is best described in the next, in this visual, where here we've taken individual colonoscopy episodes in a given market. There are lots of them. The blue bars, it's a stacked bar of blue and red, and the blue portion represents what you could broadly ascribe to be typical costs, and then the red are examples of what we call potentially avoidable complications. And some of them are relatively benign. Some of them are not. So some of them are far more expensive than others, but they're very few. Right? The average, by the way, as the slide says, the average across all these episodes is $24. Right? So, yeah, there's some that are very expensive, but on average it's a relatively low amount. But here's the point I'm trying to make, which is, so you have a patient, and the patient has a diagnostic colonoscopy. They're paying a fair amount of money, and then let's say something happens. Is it okay that they pay for the snafus? They would say, no, it's not okay that I would pay for the snafus because I don't do that anywhere else. Right? I don't do that for anything else that I buy, especially something that is as routine or seems to be as routine, or what the industry is telling me is incredibly routine, like a colonoscopy, where the frequency of the snafus isn't great. But when it does happen, should I be footing that bill in addition to having taken out of my own pocket $2,000, $3,000, $4,000? The answer, generally speaking, is no. So when we talk about bundles, it's not just a concept of how you pay, but it's really baking in this concept that it is up to the providers in a discrete way to take on the responsibility for those additional costs. It should not be up to the consumer, and it shouldn't be up to the employer, right? I mean, there's no fundamental reason why employers have to bear that cost. And the reality is, when you look at these average costs, it's not the employer picking this up. It is the consumer. That's the point. The height of these stacked columns doesn't get close to the family deductible. It doesn't get close to the individual deductible in many cases. So it truly is coming out of the consumer's pocket. So let's talk a little bit about the price variation piece, because now we took the stack of these episodes, we took out all the complications, and what we wanted to see is what is the variability that exists in the price. And as you can imagine, it's all driven by site of service. So yeah, I think there's an incredible responsibility, increasingly, whether it's fair or not fair, it's the way the market's going. There's an incredible responsibility on the part of physicians to understand this information, to get it from their payers, so that they can help guide the decision of their patients. And here's the other thing, interesting thing that's happening, and I know we talked a lot about primary care physicians and how many of these incentives are driven on them, but there's a trickle-down effect here on the PCP. right? So if the PCP ends up by referring the patient to a GI group that always sends their patients into an $8,000 facility, at some point that PCP is going to get real negative feedback, both from their patients who say, holy cow, you told me on average it was $2,500 and ended up by being $8,000. And second, they're going to get dinged by their payers, whether it's CMS or others. Well, not CMS because price is fixed, but on the commercial payers and employers, either through reference pricing or other mechanisms, they're going to start getting dinged. So the primary care physician is finding themselves to be as much stewards of the financial health of the consumer as well as their physical health, and these awkward conversations about cost, because I know these are awkward conversations in healthcare, they're happening, and they should happen. Because it is very important for the people who pay the bill, and the people who pay the bill are the consumers. So, yeah, we know that as a result of which, those who are charging $8,000 for something that you can get from two aren't going to be able to do that for very long. That's good for the American consumer, right? That is good for the American consumer. So we should applaud the fact that transparency is and should have a good effect in decreasing what anyone in any other market would look at relatively egregious pricing. All right, so now let's flip to conditions, because it's a very different picture, and it's also very important to understand what happens when we look at different conditions, and again, the effects that complications can have on the total cost of those conditions. And it's a very different picture when you look at diverticulitis than UC. And in diverticulitis, we are seeing far more expensive complications on the tail of the distribution, which has two effects. One, it has a tendency to increase the average, but two, it also, I think, creates lots of opportunities, right? And I say that seriously because the frequency of some of these things, again, is relatively low, but when they happen, they're expensive. And this is an area where improving quality, improving processes of care, improving the experience of the patient, reducing complications ends up by being a win for everyone. Right? Because if you're paid a budget for diverticulitis, today that budget is going to be artificially drawn, right, is going to be artificially skewed because of the level of complications. So if you're doing really well in managing those patients, you're actually going to end up by making a lot of money. And for those who are on the tail end of this, as they reduce the complications, they're also going to turn that into margin. So this is actually really good news, generally speaking, for physician groups and for specialty APMs. It's pretty bad news for facilities across the board, because most of this red ends up by being revenue for facilities. When bad things happen to patients, they end up in the hospital. They don't end up in ambulatory care centers. So, and this is an ongoing tension that we see both at the federal level, at the state level, and with commercial payers, where I think we all know that specialty care APMs can be managed in such a way by the specialists, by the physicians, that it is going to yield very significant margin on a per-patient basis. That margin comes at the expense of hospital revenue. And so for those practices that are owned by the hospital, there's a schizophrenic type of problem that occurs in trying to figure out who do I really need to serve. But I think more importantly over time, at least from our perspective, we see that this is going to create the reverse of what's happened over the past several years, which is the acquisition of physician practices by health systems, into a devolution of those acquisitions when physician specialty APMs or physician APMs really start taking on their own, because you will almost always be better off independent than acquired by a facility. And it's not just about this, but go back to here, right? Who's on the tail of this distribution? It's typically not the standalone facilities, right? So there's a tension at multiple levels. One is the pricing of services, that, site of service matters, and expensive site of service drives higher prices at no change in quality. And then when bad things happen, it's a revenue for one, it's an expense for the other. And so decreasing those expenses actually ends up by being beneficial for some and not for others. So let's finish with just a few implications, and I mentioned these. The cost of complications for routine procedures are minimal. So people get worried about, my gosh, if I have to give a warranty, what happens to it? Any plan will sell you a reinsurance policy for $24 if that's all it is. It's nothing, and pretty much any GI group that I know can afford to pay $24 in reinsurance if that's what it took to spread out the risk of complications over a large number of episodes. So it's a really small frequency of occurrence, but the message is so powerful. Right? The message to consumers is just so powerful. If something bad happens, it's not going to come out of your pocket. Right? We take responsibility for that. Think about what happened in the auto industry, and I know you guys hate the analogy to the auto industries, but it's not the point about, it's not, I understand this isn't mechanics. The point is, think about what happened to the shifts in market share when you finally had an auto manufacturer that said, if something like this happens, we'll pay for it. And then it's happened across all kinds of industries. But it almost destroyed an entire industry of incumbents who were completely deaf to the needs of the consumers. And the same thing will happen here, right? Those that understand the power of the message in the ability to respond to growing consumer needs are going to completely shift the way the market currently functions. And then transparency is going to lead to price compression. There's absolutely no question about that. Right? That's why the forces that usually fight against price transparency are the usual suspects. And if I were them, I would be doing exactly the same thing. But it is inevitable. Right? It's absolutely inevitable. Because if it's your money, you're making very different decisions. And you're not going to stand for long, for people who continue to say, well, it's complicated and we can't really tell you, and in other words, you're idiots and you'll never understand. It doesn't work that way for very long. Most consumers actually are pretty smart, especially when you give them simple information. And on condition management, it really is significant margins. What we see in outside of, as I could have shown this for GERD, as was mentioned earlier, there are a lot of complications. Some of them are benign, some of them less benign, and reducing those can easily double the amount of revenue for a physician compared to what they get today. Because what's interesting is when you look at the total cost of an episode, the professional services fees are really a minority of the total episode costs. And the rest of it is eaten up by medication, labs, facilities, so on and so forth. So it really doesn't take a whole heck of a lot, when you think about it, to double the amount of revenue you get per patient simply by doing a better job at managing those patients and reducing things like avoidable complications. So ultimately, and I emphasize this all the time, it is increasingly the consumer's money. And it's not just the direct out-of-pocket expense, but I want everyone, again, to think about the fact that the premium I pay for my insurance is a portion of the cost of the total cost of care. The other portion might be subsidized a little bit by my employer, but ultimately that's coming at an expense which is less salary, less of something else. And then I have taxes that I pay for the Medicare programs, which are coming out of my pocket, and I have taxes that are paid at the state level for the Medicaid program that are coming out of my pocket, and then I have out-of-pocket expenses and deductibles and coinsurance. In other words, almost 100% of the healthcare expenses in this country are being paid for by consumers, not by magical third-party coffers, in TPAs. They're not doing that. They're keeping their coffers to pay salaries. They're not using it to subsidize costs of care. Costs of care are borne almost 100%, either through taxes, direct payment, or premium contributions by the American consumer. That's the reality. So anything we can do to improve the affordability, improve the quality, is just a general social responsibility. And as much as it's gut-wrenching to think about what is going to happen and how it is going to reshape the industry, we should applaud it. Because it means, hopefully, decreasing that 20% of expenses that are being borne by the average family to maybe something a little bit more manageable that will help them save for their kids' college education. Thank you.